Today we're going to talk about physical examination in an ENT patient. So traditionally we teach our medical students to do physical examination to a patient based on what the book says. However, times are changing right now. Just as the rest of the world, COVID-19 totally changed the scenario of our interaction with each other. This goes the same to patient interaction as well as physical examination. ENT physical examinations typically involve the orifices of the head, particularly the ears, the nose, the oral cavity, and the throat. Areas wherein the virus might be transmitted. That, coupled with the fact that the doctor has to be really close to the patient to examine him or her, puts him at a very high risk to get the virus. In fact, ENT doctors were among the first doctors who were infected early in the pandemic. There are three risk factors to make you vulnerable to the virus. The CDC tells us that these three factors make us a potential contact. So to modify these three factors makes your ENT examination a lot safer. The three factors are: first is face-to-face contact with the patient within 1 meter. Second is staying with the patient for more than 15 minutes. And the third is contact with fomites or surfaces from a COVID positive patient. With this in mind, at least for me, I have modified the way of how I examine ENT patients. Take note that there is no hard and fast rules for this. I always err on the side of caution. But I think this will be a start of many changes in the manner of how we examine ENT patients for the years to come. So let's go now on how we examine ENT patients in the time of COVID. To start the ENT examination, one must don at least a level 3 PPE. A typical level 3 PPE includes a cap, goggles or face shield, mask N95 or equivalent, a gown, and a set of gloves. Take note that this should be unique for each patient and this should be new or at least clean. I do not routinely use shoe covers because as of this moment, the WHO does not recommend it. Also, I do not use a face shield because it precludes me from using my headlight because the face shield will actually hit on the headlight. Now, this is very important. Do not ever attempt to examine a patient, an ENT patient, without proper PPEs. The reason for this, number one, you might get the virus from an asymptomatic patient. Number two, who knows, you might have the virus and pass it to your patient. So it's just being responsible. Things that you need. Basic things that you need in the ENT examination are the following. First is an otoscope. Second is a tongue depressor. Third is a headlight or a flashlight. For me, I would prefer the headlight since this will free my hands to reach out for things, to examine the patient, and etc. Okay? So it frees up your other hand when you use the headlight rather than the flashlight. The fourth is the tuning fork. Usually we use 512 hertz. There are many tuning forks, but typically we use the 500 hertz because it falls on the frequency range of the human ear. And the fifth, we use, when needed, a nasal speculum. Personally, I have the patient wear a face mask and a face shield in the clinic. Again, it is a useful tip to assume that everyone is positive. And using the face shield and also the face mask, it lets me avoid using those acrylic barriers. And these acrylic barriers will actually be a psychological barrier of your connection to the patient. So a face shield should be okay. Also, I do the physical examination after a thorough history taking with the patient. Usually, I do it outside the clinic, probably in a open space in a hallway or even to teleconsult. This way, it will minimize the examination time with the patient so as to fulfill CDC's 15-minute contact. But take note that your physical examination should be as thorough as possible, but also as rapid as possible. I always start the complete physical examination with the ear, since the patient is usually wearing a face mask or the face shield. If the patient complains of the ear problem, I usually start at the normal side, the side wherein there is no problem. The reasons for this are you first see what the normal structure of the patient's ear before seeing the abnormal diseased side, so that you could draw comparisons. Second, if you examine the problematic side first, say an infected side, you can actually bring the infection to the normal side if you examine it last. Inspection. The first part of the examination includes inspection of the external ear. Note if there is swelling, redness, color, shape, position changes, and nodules. Also inspect the entrance of the ear canal for discharges. Palpation. You can gently pull the ear away or press on the tragus for any sign of pain. These can be signs of acute otitis externa. Otoscopy. Here is when you need an otoscope. Hold the otoscope either horizontally or vertically, but always stick your little finger against the patient's head, especially for pediatric patients. This is to avoid injury over the otoscope tip when there are sudden head movements of the patient. You might need to hold and pull the pinna with one hand to straighten the canal, as it has a natural curvature to it. So hold the otoscope with your right hand while examining the right ear, and hold the otoscope with your left hand while examining the left ear. Modifications to the otoscope at this time of the COVID is, is the use of camera boroscopes. These boroscopes allow you to see inside the ear via a USB connection to your smartphone or a tablet. Usually, it already has a light source and it sells very cheap at online stores for $5 or around 250 pesos. This is a camera boroscope. You insert this into your phone and this has a digital camera which you can actually insert to the patient's ear. It already has a light source and you will have a fair amount of distance when examining the ear. So it avoids you being too close to the patient. On otoscopy, you will inspect the ear canal first, noting for skin inflammations, wax, or foreign bodies. Advance the speculum forward until you see the eardrum. It should appear as a pearly gray or translucent film. Note the anatomical landmarks of the tympanic membrane like pars flaccida, pars tensa, malleus, and the cone of light. The cone of light is usually found in the anterior inferior portion of the eardrum, usually at the 5 o'clock or 7 o'clock position, depending on which ear you are looking at. Assess the tympanic membrane for color, like redness, shape, like bulging, or perforations, which is usually assessed by percentages. An otoscopic examination is complete once you see all the structures. That's why, in some patients, you might need to do ear cleaning first. Once complete, replace the speculum and repeat this on the other side. Hearing examinations. The basic hearing examinations done in the clinic are: first, the whispered voice test; second is the Weber lateralization test; and the third is the Rene's test. The first exam is the whispered voice test. Take note that this is a screening test. Once the patient cannot pass this test, you would suspect that patient indeed has a hearing problem and will prompt you to evaluate patient further in a formal hearing center. To go about with a whispered voice test, make sure first that you are in a quiet room and make sure that there are no loud ambient sounds like traffic noise or aircon noise. To start the whispered voice test, stand behind the patient around 2 feet away so that the patient cannot read your lips. Tell the patient to cover one ear. Quietly whisper a combination of three numbers or letters in your own preference and ask the patient to repeat it back to you. Do it again with another combination. If the patient repeats at least 3 out of 6 letters or numbers, it is considered to be normal. Otherwise, an abnormal sequence suggests a gross hearing loss on the tested ear. Repeat this process over the other ear. If the patient has abnormal findings in this test, you can tell the patient to undergo a formal hearing test. It is called a pure tone audiometry, wherein patient is placed in a soundproof room in a hearing center, listens to a number of sound at different frequencies and volumes, and presses a button if they can hear this. The second hearing examination done at the clinic is the Weber test. This is a test of lateralization. And take note, you can only use this in patients with unilateral hearing loss. Bilateral hearing loss will not lateralize. You need to use a 512 Hz tuning fork in this test. Set the fork into light vibration by briskly stroking it between the thumb and index fingers in the manner shown in the video. Or better yet, by tapping it against your forearm near your elbow. Quickly place the base of the tuning fork firmly against the patient's mid forehead or on top of the patient's forehead. Then ask the patient where he or she hears the sound. Normally, patients can hear the sound on both ears. In patients with conductive hearing loss, patients will hear the sound better in the poor ear. In patients with sensory neural hearing loss, the patient will hear the sound in the better ear. The reason for this is that normally the ear receives two inputs of sound, one coming from the air through the ear canal, eardrum, ossicles, and finally to the bony cochlea, and one coming from the bone of the skull, which travels directly to the bony cochlea bypassing everything else. Basic physics tells us that sound waves travel faster in solids than in air medium. Thus, when there is conductive hearing problem, there is still a tuning fork sound traveling on the cochlea, and the absence of ambient sounds other than the tuning fork, a louder sound is heard. If on the other hand, if the cochlea isn't really functioning, sound is never heard, and patient will hear the sound on the other ear instead. The next test will be the Rene's test. It will test both ear and bone conductions in one ear. Start by firmly pressing the base of the vibrating tuning fork against the mastoid bone. Tell the patient to listen to the sound and tell you if he or she cannot hear the sound anymore. Then, quickly hold the tuning fork next to the patient's ear and ask the patient if he or she can still hear any sound. If the patient hears a sound, it means a positive Rene's test and is normal air conduction. If the patient cannot hear a sound anymore, it means a negative Rene's test and is indicative of a conductive hearing loss. The nose. The next is the examination of the nose. Modification of this examination include having the patient lower his face mask and briefly show his nose to the face shield on inspection. Grossly inspect the anterior and inferior surfaces of the nose. Take a look at the skin changes of the nose, as well as deformities and deviations. When indicated, you test the patient for nasal obstruction. Tell the patient to press on one ala and breathe in. Ask them if the nasal cavity is obstructed. Then repeat this on the other side. Usually, we use the otoscope in examining the insides of our nostrils. We take a look at the septum, the inferior turbinates, the middle turbinates, and the space in between them, which is the middle meatus. But since using an otoscope means that we have to be really near the patient and exposed to the nasal cavity, but we can substitute the otoscope with a borescope as mentioned earlier, or better yet, by using a headlight or a flashlight and a nasal speculum. You can actually buy a nasal speculum online. The nasal speculum is held with the thumb resting just within the hinge. You insert the speculum unopened, then dilate it once inside the nasal cavity. You can move it around to look for structures and examine the nose, but when you withdraw it open to avoid grasping the hairs while you're withdrawing it. Hold the speculum with your right hand to examine the left nostril of the patient and with your left hand to examine the right nostril of the patient. Inspect the nasal mucosa, the nasal septum, the turbinates, and any discharges or masses intranasally. Look for sources of bleeding, especially in the septum, or yellowish discharge coming from the middle meatus, which is the space between the inferior and the middle turbinates. Take note that inspection of the nasal cavity done this way is limited to examining the structures of the anterior nose. Examination of the posterior nose is usually done using a dental mirror through the mouth and looking at the posterior structures from behind. Also, ENTs right now already uses a video endoscope to examine the nose to have some distance from the patient. Palpate for sinus tenderness. Gently press the medial brows, the sides of the nasal bones, and the cheeks to check for tenderness. A combination of nasal discharge, nasal obstruction, and local tenderness in these areas highly suggests a bacterial sinusitis. Mouth and pharynx. Observe the lips for color, moisture, cracking, or nodules. Examine the mouth if possible. Have the patient lower his or her mask and look at the mouth through the face shield. Have the patient move the tongue and note for fasciculations or deviations on protrusions. You can also examine the hard palate and the soft palate at this point. Using a tongue depressor, examine the upper and lower gums, the buccal mucosa, and the floor of the mouth. At this point, you can also locate the ducts of the drainage of the parotid gland, the submandibular gland, and the sublingual gland, as indicated. Using the same tongue depressor, gently depress the tongue in its anterior two-thirds to examine the tonsils as well as the posterior pharyngeal wall. You can tell the patient to say "ah" so that the soft palate will elevate to give you a better view of the posterior pharyngeal wall. Just be careful not to depress the tongue on its posterior one-third because this will cause gagging. Examine for the size of the tonsils and look for tonsillar exudates or postnasal drip or posterior pharyngeal mucosa irritation. Palpation and percussion. If it's needed, you can also palpate to the tongue by holding it with a piece of gauze and palpating the tongue tissue using your other hand. You can also percuss the tooth using any metallic instrument, preferably a dental mirror, to elicit unusual pain from tooth root abscesses. The neck. Have the patient extend their head to see the neck. Start by inspecting the neck and note for masses, skin changes, asymmetry, or if there are any enlargements of the parotid glands and submandibular glands. Then, have the patient turn to one side and the next. Typically, I visualize the neck into anterior and posterior necks, with an imaginary line from the mastoid down to the sternum as the dividing line. The posterior neck usually contains mostly muscles, so I don't worry about finding anything behind this imaginary line. It is also okay to subdivide the neck using the neck node levels, especially if you're going to suspect lymph nodes. Level 1 is below the chin until the submandibular gland. Level 2 is along the upper one-third of the sternocleidomastoid muscle. Level 3 is on the middle third of the SCM. Level 4 is in the lower third of the SCM. Level 5 is actually in the posterior neck, and level 6 is found centrally, in front of the SCM but below the hyoid bone. Also, inspect the thyroid gland. It is usually found beneath the cricoid prominence, which is also below the thyroid prominence, or Adam's apple in men. To delineate the thyroid gland, ask the patient to swallow saliva or water because this will elevate the trachea, which in turns elevate the thyroid attached to that trachea. If one is suspecting a thyroglossal duct cyst, have the patient stick out their tongue and notice the upward movement of the suspected cyst, which confirms the diagnosis. Palpation. Stand behind the patient and have the patient extend their head and do the palpation of the neck with both hands. Personally, I follow the pattern of the neck lymph node levels, with the addition of the preauricular and postauricular areas as needed, so that I have a system to follow. Doing this way of examination, you will end up at the level 6 or around the thyroid area, and here you can already start to palpate the thyroid as well. Move the trachea left and right to delineate the thyroid, and as needed, tell the patient to swallow saliva or water to elevate it. Note the size, shape, and the consistency of the thyroid gland. Auscultation. If the thyroid gland is noted to be enlarged, using a stethoscope, listen for bruit, which can sound like a murmur. You can also auscultate the upper trachea and listen for stridor should you suspect a tracheal origin of the airway obstruction. Other auscultations done in the neck include listening for bruit in the carotid area, which may indicate carotid stenosis. The face. Inspect the face for scars, lesions, and deformities. Have the patient raise their eyebrows, close eyes, smile, puff face, and frown to test for the integrity of cranial nerve 7. You can have the patient visually follow your hand movements to test the integrity of extraocular muscles and thus cranial nerves 3, 4, and 6. Test cranial nerve 5 or V by comparing the sensations of the left side of the face compared that to the right. Cranial nerve V1 is tested by brushing the skin of the supraorbital area and comparing it to the other side. Cranial nerve V2 is brushing the skin of the cheek, and cranial nerve V3 is brushing the skin to the mandible. So there you have it, the basic ENT physical examinations. There are a lot more physical examination techniques that you will have to learn once you go to ENT. However, these techniques should suffice in your daily practice. If you have any questions or need any help with regards to examining an ENT patient in your clinic, feel free to contact any of us, your residents, the consultants, or your teachers in the college. We will be very glad to help you. Always remember, in the business of medicine, two brains is better than one. So it's more of a collaborative effort, especially when you are dealing with complex cases. So asking for help is never a bad idea. I'm sure all of you are home right now, and I really hope that you are safe. We all know that clinical experience is needed to become a better doctor. However, at the time of COVID, this should help you at least have an idea of what we do in the clinics. And I always tell this, that knowing is half the battle.
And knowing is half the battle.
Being a doctor is being in a battle. And knowing what you're doing is half of it. Okay? So, while you're at home, you learn a lot. And I think you're halfway there. You're halfway doctors. So, thank you and stay safe.